Next session is about carbon dioxide transport. Carbon dioxide transport. In the body's tissue cells, oxygen reacts with various foodstuffs to form large quantities of carbon dioxide. The CO2 enters the tissue capillaries and is transported back to the lungs. Carbon dioxide, like O2, also combines with chemical substances in the blood that increase CO2 transport 15 to 20 fold. The purpose of this chapter is to present both quantitatively and qualitatively the physical and chemical principles of CO2 transport in the blood and tissue fluids. Later, we will be learn about the neural control of this respiration process. So, transport of carbon dioxide in the blood. Transport of CO2 by the blood is not nearly as problematic as transport of O2. Is because even in the most abnormal conditions, CO2 can usually be transported in far greater quantities than can O2. However, the amount of CO2 in the blood has a lot to do with acid-base balance of body fluids, which is discussed later. So, under normal resting conditions, an average of 4 ml CO2 is transported from the tissues to the lungs in each 100 ml of blood. Chemical forms in which carbon dioxide is transported. To begin the process of CO2 transport, CO2 diffuses out of the tissue cells in the dissolved molecule of CO2 form. On entering the tissue capillaries, the CO2 initiates a host of almost instantaneous physical and chemical reactions, and which are discussed later. So, transport of carbon dioxide in the dissolved state. A small portion of CO2 is transported in the dissolved state to the lungs. Recall that the pCO2 of venous blood is 45 mmHg and that of arterial blood is 40 mmHg. The amount of CO2 dissolved in the fluid of the blood at 45 mmHg is about 2.7 ml per dl, 2.7 volume percentage. The amount dissolved at 40 mmHg is about 2.4 ml or a difference of 0.3 ml. Therefore, only about 0.3 ml of CO2 is transported in the dissolved form by each 100 ml of blood flow. This is about 7% of all the CO2 normally transported. Then transport of carbon dioxide in the form of bicarbonate ion. Reaction of carbon dioxide with water in the red blood cells. Effect of carbonic anhydrase. The dissolved CO2 in the blood reacts with water to form carbonic acid. CO2 plus water, carbonic acid. This reaction would occur much too slowly to be of importance, where it not for the fact that inside the red blood cell is a protein enzyme called carbonic anhydrase. It's an enzyme called carbonic anhydrase which catalyzes the reaction between CO2 and water and accelerates its reaction rate about 5,000 fold. Therefore, instead of requiring many seconds or minutes to occur, as it true in the plasma, the reaction occurs so rapidly in the red blood cell that it reaches almost complete equilibrium within a small fraction of a second. This phenomenon allows tremendous amounts of CO2 to react with the red blood cell water even before the blood leaves the tissue capillaries. Then dissociation of carbonic acid into bicarbonate and hydrogen ions. In another fraction of a second, the carbonic acid formed in the red cells H2CO3 dissociate into hydrogen and bicarbonate ions H plus and HCO3 minus. Most of the H plus ions then combine with hemoglobin in the red blood cells because hemoglobin protein is powerful acid-base buffer. Hemoglobin protein is a powerful acid-base buffer. Never forget that. In turn, many of the HCO3 minus ions diffuse from the red blood cells into the plasma, while chloride ions diffuse into the red blood cells to take their place. The diffusion is made possible by the presence of a special bicarbonate chloride carrier protein in the red blood cell membrane that shuttles these two ions in opposite directions at rapid velocities. Thus, the chloride content of venous red blood cell is greater than that of arterial blood cells, a phenomenon called the chloride shift. What is chloride shift? Chloride content of venous red blood cells is greater than that of arterial blood cells. Chloride content in arterial blood cells is higher. So that process is called chloride shift. The reversible combination of CO2 with water in the red blood cells under the influence of carbonic anhydrase accounts for about 70% of the CO2 transported from the tissues to the lungs. This means of transporting CO2 is by far the most important. Indeed, when a carbonic anhydrase inhibitor, or for example acetozolamide, acetozolamide is administered to an animal to block the action of carbonic anhydrase in the red blood cells, CO2 transport from the tissues become so poor that the tissue's pCO2 may rise to 80 mmHg instead of the normal 45 mmHg. The next, transport of carbon dioxide in combination with hemoglobin and plasma protein. Carbaminohemoglobin. Carbaminohemoglobin. In addition to reacting with water, CO2 reacts directly with amine radicals of the hemoglobin molecule to form the compound carbaminohemoglobin, CO2HgB. CO2HgB, small b. This combination of CO2 and hemoglobin is a reversible reaction that occurs with a loose bond. So the CO2 is easily released into alveoli where the pCO2 is lower than the pulmonary capillaries. A small amount of CO2 also reacts in the same way with the plasma protein in the tissue capillaries. This reaction is much less significant for the transport of CO2 because the quantity of these proteins in the blood is only 1/4 as great as the quantity of hemoglobin. Then the quantity of CO2 that can be carried from the peripheral tissues to the lungs by carbamino combination with hemoglobin and plasma proteins is about 30% of the total quantity transported. That is normally about 1.5 ml of CO2 in each 100 ml of blood. However, because this reaction is much slower than the reaction of carbon dioxide with water inside the red blood cells, it is doubtful that under normal conditions, this carbaminohemoglobin transports more than 20% of total CO2. Next topic, diffusion of carbon dioxide from the peripheral tissue cells into the capillaries and from pulmonary capillaries into the alveoli. When O2 is used by the cells, virtually all of it becomes CO2 and its increase the intracellular pCO2. Because of this high tissue cell pCO2, CO2 diffuses from the cells into the tissue capillaries and is then carried by blood to the lungs. In the lungs, it diffuses from pulmonary capillaries into the alveoli and is expired. Next, diffusion of carbon dioxide from the peripheral tissue cells into the capillaries and from pulmonary capillaries into the alveoli. When O2 is used by the cells, virtually all of it becomes CO2 and it increases the intracellular pCO2. Because of this high tissue cell pCO2, CO2 diffuses from the cell into the tissue capillaries and is carried by the blood to the lungs. In the lungs, it diffuses from the pulmonary capillaries into the alveoli and is expired. Thus, at each point in the gas transport chain, CO2 diffuses in the direction exactly opposite to the diffusion of O2. Yet, there is one major difference between diffusion of CO2 and O2. CO2 can diffuse about 20 times as rapidly as O2. Therefore, the pressure difference required to cause CO2 diffusion are in each instance far less than the pressure difference required to cause O2 diffusion. The CO2 pressure are approximately the following: intracellular pCO2 46 mmHg, interstitial pCO2 45 mmHg. Thus, there is only 1 mmHg present. That is the pressure difference. So, pCO2 of the arterial blood entering the tissue 40 mmHg, pCO2 of the venous blood leaving the tissue 45 mmHg. Thus, the tissue capillary blood comes almost exactly to equilibrium with the interstitial pCO2 at 45 mmHg. pCO2 of the blood entering the pulmonary capillaries at the arterial end 45 mmHg, pCO2 of the alveolar air 40 mmHg. Thus, only a 5 mmHg pressure difference causes all the requiring CO2 diffusion out of the pulmonary capillaries into the alveoli. Furthermore, pCO2 of the pulmonary capillary blood falls to almost exactly equal the alveolar pCO2 of the 40 mmHg before it has passed more than about 1/3 the distance through the capillaries. This is the same effect that was observed earlier for O2 diffusion, except that it is the opposite direction. Effective rate of tissue metabolism and tissue blood flow on interstitial pCO2. Next topic, tissue capillary blood flow and tissue metabolism affect the pCO2 in ways exactly opposite to that effect of tissue PO2. A decrease in blood flow from normal to quarter normal increases peripheral tissue pCO2 from the normal value of 45 mmHg to an elevated level of 60 mmHg. Then carbon dioxide dissociation curve. Carbon dioxide dissociation curve depicts the dependence of total blood CO2 in all of its forms on pCO2. Note that the normal blood pCO2 ranges between a narrow range of 40 mmHg in the arterial blood and 45 mmHg in venous blood. Note also that normal concentration of CO2 in the blood in all its different forms is about 50 volume percentage, but only 4 volume percentage of this exchanged during normal transport of CO2 from the tissue to the lungs. That is, the concentration rises to about 52 volume percentage as the blood passes through the tissues, as falls to 48% volume percentage as it passes through the lungs. When oxygen binds with hemoglobin, carbon dioxide is released. The Haldane effect to increase CO2 transport. When oxygen binds the hemoglobin, carbon dioxide is released. The Haldane effect to increase the CO2 transport. We pointed out that an increase in CO2 in the blood causes O2 to be displaced from the hemoglobin. The Bohr effect. Increase in CO2 of the blood causes O2 to be displaced. This is an important factor in increasing O2 transport. The reverse is also true. Binding of O2 with hemoglobin tends to displace CO2 from the blood. Indeed, this effect, called the Haldane effect, is quantitatively far more important in promoting CO2 transport than is the Bohr effect in promoting O2 transport. What is the Haldane effect? The Haldane effect results from the simple fact that combination of oxygen and hemoglobin in the lungs causes the hemoglobin to become a stronger acid. This displaces carbon dioxide from the blood and into the alveoli in two ways. The more highly acidic hemoglobin has less tendency to combine with carbon dioxide to form a carboxyhemoglobin. The more highly acidic hemoglobin has less tendency to combine with carbon dioxide to form carbaminohemoglobin, thus displacing much of the carbon dioxide that is present in the carbamino form from the blood. The increased acidity of the hemoglobin also causes it to release an excess of hydrogen ions and this bind with bicarbonate ions to form carbonic acid. This then dissociates into water and carbon dioxide, and the carbon dioxide is released from the blood into the alveoli and finally into the air. When PO2 is 100 mmHg, which is the case with the blood capillaries of the lungs, and PO2 is 40 mmHg, which is the case in the blood tissue capillaries, like that. There will be some explanations. And change in blood acidity during CO2 transport. Changes in blood gases during hypoventilation and hyperventilation. Blood gas measurements can be monitored either using non-invasive methods or using invasive methods. The invasive methods are described later, so include the measurements of blood PO2, CO2 and pH. The arterial blood gas measurement is one of the commonly used techniques for measuring PO2, CO2, pH and bicarbonate. This measurement technique requires an arterial blood sample of a few millimeters and is highly reliable and reproducible. So hypoventilation may occur if the respiratory centers are affected by injury or are depressed due to various other reasons. Some of the causes include damage to the nerve supply of the respiratory muscles, spinal cord injuries, conditions such as myasthenia gravis that affect the neuromuscular junction, and dysfunction of the lung mechanics such as chest wall injuries, kyphoscoliosis and airway obstruction. Kyphoscoliosis, which is nothing else but the curvature of the spine will be tilted, and airway obstruction. In those individuals who ascend to high altitudes, alveolar hypoxia may occur due to decreased barometric pressure at a higher altitude. Both hypoventilation and ascent to high altitude cause alveolar hypoxia, decreased arterial PO2 and increased CO2 levels in blood, hypercapnia. Ultimately, hypoventilation will lead to respiratory acidosis, reduces pH with elevated CO2, and this is compensated by renal HCO3 minus retention and excitation of H plus ions by the kidneys. Acid-base monograms Davenport diagram allow simultaneous plotting of pH, CO2 and HCO3 minus and help in understanding the interpreting mixed respiratory and metabolic acid-base disturbances. Then hyperventilation. Hyperventilation is a condition where the rate of alveolar ventilation is increased more than the rate of CO2 production by metabolic processes. This leads to a decrease in arterial PO2 levels, PCO2 levels well below the normal PCO2 range. Conditions such as tachypnea, I'm not sure about the pronunciation, increase in respiratory rate, and hyperpnea, increase in minute ventilation, should be differentiated from hyperventilation. Both tachypnea and hyperpnea do not cause changes in arterial PCO2 levels. The cause of alveolar hyperventilation could be due to an excessive ventilatory drive caused by the either behavioral or metabolic regulatory systems. Some of the causes for hyperventilation include hypoxemia caused by pulmonary disease, pneumonia, cardiovascular disorders such as congestive cardiac failure, metabolic disorders such as acidosis, hepatic failure, neurological causes such as psychogenic or anxiety, hyperventilation, drugs such as salicylates, beta-adrenergic agnosis, and miscellaneous causes such as fever, sepsis, and pregnancy. In conditions where the arterial PCO2 is very low due to hyperventilation, it may temporarily cause apnea because of the reduced temporarily ventilatory drive. CO2 that is produced by metabolic process will then build up and restore the ventilator drive. Chronic hyperventilation leads to respiratory alkalosis. Respiratory exchange ratio R is equal to rate of carbon dioxide output by rate of oxygen uptake. Next topic, neural regulation of respiration. In this topic, we are going to learn some aspects of centers of respiration and describe their organization, enumerate the peripheral inputs affecting respiration, then including the peripheral receptors, describe the Herring-Brewer reflex, Hering-Brewer reflex. I'm not sure about the pronunciation, so I'm just giving the spelling. Then describe the different types of abnormal breathing patterns. So these are the major learning objectives. The nerve system normally adjusts the rate of alveolar ventilation almost exactly to the demands of the body so that the oxygen potential pressure PCO2, oxygen partial pressure, and carbon dioxide partial pressure there is a mismatch. So oxygen partial pressure PO2 and carbon dioxide partial pressure PCO2 in the arterial blood are hardly altered, even though heavy exercise and most other types of respiratory stress. This chapter describes the function of this neurogenic system for regulation of respiration. Respiratory center. The respiratory center is composed of several groups of neurons located bilaterally in the medulla oblongata and pons of brainstem. So it was the organization of the respiratory center. When we try to learn about its parts, we could see pneumotaxic center, apneustic center, fourth ventricle, dorsal respiratory group, inspiration, dealing with inspiration, then ventral respiratory group, expiration and inspiration, then vagus and glossopharyngeal nerve, then respiratory motor pathways. A dorsal respiratory group located on the dorsal portion of the medulla, which mainly causes inspiration. A ventral respiratory group located in the ventrolateral part of the medulla, which mainly causes expiration. The pneumotaxic center located dorsally in the superior portion of the pons, which mainly controls rate and depth of breathing. Which are the dorsal respiratory group, ventral respiratory group, pneumotaxic center. Dorsal respiratory group, ventral respiratory group, and pneumotaxic center. Dorsal respiratory group of neurons, its control of inspiration and that of respiratory rhythm. The dorsal respiratory group of neurons play a fundamental role in the control of respiration and extends most of the length of the medulla. Most of its neurons are located within the nucleus of the tractus solitarius. Nucleus of the tractus solitarius or NTS. Although additional neurons in the adjacent reticular substance of the medulla also play important roles in the respiratory control. The NTS is the sensory termination of both the vagal and the glossopharyngeal nerves, which transmit sensory signals into the respiratory center from peripheral chemoreceptors, baroreceptors, several types of receptors in the lungs. Rhythmical inspiratory discharge from the dorsal respiratory group. The basic rhythm of respiration is generated mainly in the dorsal respiratory group of neurons. Even when all the peripheral nerves entering the medulla have been sectioned and the brainstem has been transected both above and below the medulla, the group of neurons still emits repetitive bursts of inspiratory neuron action potentials. The basic cause of this repetitive discharge is unknown. In primitive animals, neural networks have been found in which activity of one set of neurons excites a secondary set, which in turn inhibit the first. Then after a period, the mechanism repeats itself, continuing throughout the life of the animal. Most respiratory physiologists believe that some similar networks of neurons is present in human being located entirely within the medulla. It probably involves not only the dorsal respiratory group but adjacent areas of medulla as well, and is responsible for the basic rhythm of inspiration. Inspiratory ramp signal (RAMP). The nerve signal that is transmitted to the inspiratory muscles, mainly the diaphragm, is not an instantaneous burst of action potentials. Instead, it begins weakly and increases steadily in a ramp manner for about 2 seconds in normal respiration. It then ceases abruptly for approximately the next 3 seconds, which turn off the excitation of the diaphragm and allows elastic recoil of the lungs and the chest wall to cause expiration. Next, the inspiratory signals begin again for another cycle. This cycle repeats again and again with expiration occurring in between. Thus, the inspiratory signal is a ramp signal. The obvious advantage of ramp is that it causes a steady increase in the volume of lungs during inspiration rather than inspiratory gasps. So, when we try to learn about neural control of respiration, we could see portions like higher centers, other receptors in the lungs, chemoreceptors, central and peripheral, pneumotaxic center. These portions, activating or inhibiting the dorsal group of neurons, firing inhibitory ramp signal. Then somatic neurons are activated for inspiration. Then contraction of diaphragm and external intercostal muscles will be taking place that lead to increase in inspiration. Along with that, ventral group of neurons are also activated, which lead to somatic neurons expiration and inspiration connection. Then contraction of internal, intercostal and abnormal muscles, increase in expiration. Two qualities of the inspiratory ramp that are controlled are as follows. Control of the rate of increase of the ramp signal, so that during heavy respiration, the ramp increases rapidly and therefore fills the lungs rapidly. Control of the limiting point at which the ramp suddenly ceases, which is the usual method for controlling the rate of respiration. That is, earlier the ramp ceases, the shorter the duration of inspiration. This method also shortens the duration of expiration. Thus, the frequency of respiration is increased. The pneumotaxic center limits the duration of inspiration and increases respiration rate. A pneumotaxic center located dorsally in the nucleus parabranchialis of the upper points transmits signals to the inspiratory area. The primary effect of this center is to control the switch off point of the inspiratory ramp, thus controlling the duration of the filling phase of the lung cycle. When the pneumotaxic signal is strong, inspiration might last for as little as 0.5 seconds, thus filling the lungs only slightly. When the pneumotaxic center is weak, inspiration might continue for 5 or more seconds, thus filling the lungs with a great excess of air. The function of the pneumotaxic center is primarily to limit inspiration, which has a secondary effect on increasing the rate of breathing, because limitation of inspiration also shortens expiration and the entire period of each respiration. A strong pneumotaxic signal can increase the rate of breathing 30 to 40 breaths per minute, whereas a weak pneumotaxic signal can reduce the ratio and the rate to only 3 to 5 breaths per minute. Then ventral respiration group of neurons, functions of both inspiration and expiration. Located in each side of the medulla, about 5 mm anterior and lateral to the dorsal respiratory group of neurons, is a ventral respiratory group of neurons found in the nucleus ambiguus rostrally and the nucleus retroambiguus caudally. Rostrally and caudally. Nucleus ambiguus rostrally and nucleus retroambiguus caudally. The function of the neuron group differs from that of the dorsal respiratory group in several important ways. The neurons of the ventral respiratory group remains almost totally inactive during normal quiet respiration. Therefore, normal quiet breathing is caused only by repetitive inspiratory signals from the dorsal respiratory group transmitted mainly to the diaphragm, and expiration results from elastic recoil of the lungs and thoracic cage. So the ventral respiratory neurons do not appear to participate in the basic rhythmical oscillation that control respiration. When the respiratory drive for increased pulmonary ventilation becomes greater than normal, respiratory signals spill over into the ventral respiratory neurons from the basal oscillating mechanism of the dorsal respiratory area. As a consequence, the ventral respiratory area contributes extra respiratory drive as well. Electrical stimulation of a few of the neurons in the ventral group causes inspiration, whereas stimulation of others causes expiration. Therefore, these neurons contribute to both inspiration and expiration. They are especially important in providing the powerful expiratory signals to the abdominal muscles during very heavy expiration. Thus, the area operates more or less as an overdrive mechanism, with high levels of pulmonary ventilation are required, especially during heavy exercise. Then the peripheral inputs affecting the respiration, including the peripheral receptors. There are several peripheral receptors that help in the control of respiration. The levels of oxygen and carbon dioxide are detected by central and peripheral chemoreceptors, and this is very important. The other peripheral receptors that have an influence on respiration are mechanoreceptors and are listed. The hearing, a brewer inflation reflex, lung inflation signals limit inspiration. In addition to the central nervous system, a respiratory control mechanism operating entirely within the brainstem. Sensory nerve signals from the lungs also help control respiration. Most important, located in the muscular portions of the walls of the bronchi and the bronchioles throughout the lungs are stretch receptors that transmit signals through the vagi into the dorsal receptors group of neurons when the lungs become overstretched. These signals affect inspiration in the same way as signals from the pneumotaxic center. That is, when lungs become overly inflated, the stretch receptor activates an appropriate feedback response that switches off the respiratory ramp, inspiratory ramp, and this stops further inspiration. This mechanism is called Herring-Brewer inflation reflex. This reflex also increases the rate of respiration, as is true for signals from the pneumotaxic center. In humans, the Herring-Brewer reflex probably is not activated until the tidal volume increases to more than 3 times normal. Therefore, this reflex appears to be mainly a protective mechanism for preventing excess lung inflation rather than an important ingredient in normal control of ventilation. Control of overall respiratory center activity. Up to this point, we have discussed the basic mechanism for causing inspiration and expiration, but it is also important to know how the intensity of the respiratory control signals is increased or decreased to match the ventilatory needs of the body. For example, during heavy exercise, the rates of O2 usage and CO2 formation are often increased so as much as 20 times normal, requiring commensurate increase in pulmonary ventilation. The major purpose of remainder of this chapter is to discuss the control of ventilation to accommodate the respiratory needs of the body. Other factors that affect respiration. Voluntary control of respiration. Effect of irritant receptors in the airways. The epithelium of the trachea, bronchi, and bronchioles is supplied with sensory nerve endings called pulmonary irritant receptors that are stimulated by many incidents. These receptors initiate coughing and sneezing. They also cause bronchial constriction in persons with such diseases as asthma and emphysema. Pulmonary irritant receptors. Then functions of lung, J receptors. A few sensory nerve endings have been described in the alveolar walls in juxtaposition to the pulmonary capillaries, hence the name J receptors. These J receptors were first described by an Indian scientist Arthur Singh Paintal. I'm not sure about the pronunciation. He discovered this in 1955. They are stimulated especially when the pulmonary capillaries become engorged with blood or when pulmonary edema occurs in such conditions as congestive heart failure. Although the functional role of J receptors is not clear, the excitation may give the person a feeling of dyspnea. there is nothing else but the difficulty in breathing or shortness of breath. Brain edema depresses the respiratory center. The activity of the respiratory center may be depressed or even inactivated by acute brain edema resulting from brain concussion. For instance, the head might be struck against some solid object, after which damaged brain tissue swell, compressing the cerebral arteries against the cranial wall and thus partially blocking cerebral blood supply. Occasionally, the respiratory depression results from brain edema can be relieved temporarily by intravenous injection of hypertonic solution such as highly concentrated mannitol solution. The solutions osmotically remove some of the fluids from the brain, thus relieving intracranial pressure and sometimes restabilizing respiration within a few minutes. Anesthesia. Perhaps the most prevalent cause of respiratory depression and respiratory arrest is overdosage with anesthetics or narcotics. For instance, sodium pentobarbital depresses the respiratory center considerably more than many of other anesthetics such as halothane. At one time, morphine was used as an anesthetic drug. Thus, the drug is now used only as an adjunct to anesthetics because it greatly depresses the respiratory center while having less ability to anesthetize the cerebral cortex. Types of the abnormal breathing patterns. Periodic breathing. Basic mechanism of Cane-stroke breathing. Biot's breathing. And apneustic breathing. Kussmaul's breathing. Periodic breathing. Breathes deeply for a short interval and then breathes slightly or not at all for an additional interval, and then the cycle repeats itself over and over. This type of periodic breathing, Cane-stroke breathing, is characterized of a slowly waxing and waning respiration occurring about every 40 to 60 seconds. The basic cause of this breathing is the following. A person overbreathes, thus blowing off too much CO2 from the pulmonary blood, while at the same time increasing blood O2. It takes several seconds before the changed pulmonary blood can be transported to the brain and inhibit the excess ventilation. By the time the person has already overventilated for the extra few seconds. Therefore, when the overventilated blood finally reaches the brain respiratory center, the center becomes depressed to an excessive amount, and the point in the opposite cycle begins, that CO2 increases and O2 decreases in the alveoli. Again, it takes a few seconds before the brain can respond to these new changes. Then, Biot's breathing. Rare condition where an abnormal breathing pattern occurs in a patient with acute neurological disease. This condition is also known as ataxic breathing and is characterized by unpredictable irregularity. Quick hours of shallow respiration followed by unpredictable periods of apnea or shortness of breath. This is due to lesions in the medulla oblongata. Then apneustic breathing. Apneus is derived from Greek meaning breath holding. Prolonged inspiration or a gap in the pause or with the pause or the full inspiration. Lesions in the dorsolateral lower half of the pons. Then Kussmaul's breathing. This type of abnormal breathing characterizes very few deep, labored, regular breathing, sometimes with increased frequency. It is named after a German physician.